your experience, sharing experience from your hospital will be encouraging us to improve our capability for transplantations program. On behalf of Harapan Kita Hospital, our friend here, medical staff, and the nurse, and our supporting staff, thank you for your lecture, Dr. Chen. Okay, Dr. Mira, maybe you can continue this webinar meeting. And thanks again.
Okay, thank you very much, Dr. Isman, and all professors, consultants, and their colleagues. Today we will have the first topic of the second webinar, heart transplant webinar series between National Taiwan University Hospital and Harapan Kita Hospital. And in this afternoon, we will have Dr. Chen, Dr. Chen, to have a lecture about the role of endomyocardial biopsy in monitoring heart transplantation. Dr. Chen is an attending cardiologist in National Taiwan University Hospital, and he's also a Secretary General of Taiwan Society of Heart Failure. He's a very skillful and very smart, and from my perspective, very kind lecture. Okay, Dr. Chen, you want an hour or 30 minutes? You have 30 minutes for your lecture, and the time is up.
Okay, thank you. Thank you for your kind introduction. And I would like to share my slide.
Yes. Bisa dibantu untuk menjadi co-host ya? Dokter Sarah.
Please allow me.
Boleh dibantu untuk menjadi co-host, Dokter Chen. Dokter Sarah. Ya udah. Ada.
Okay. Sorry for the time delay, and today is my honor to be invited to provide all of you with this talk entitled "The Role of Endomyocardial Biopsy in Monitoring Heart Transplant Patients." And to my opinion, is that this is really a short topic indeed, because as you may know, that heart transplant is a teamwork. The success for the heart transplant comes from all the teamwork effort. And for heart transplant, post-heart transplant surveillance, the biopsy is only one part of the heart transplant care. And I was allowed to provide this talk for about 1 hour. And maybe we can see how the things goes. If any questions you may concern, please just ask me directly. And for me, just like the introduction, I am a cardiologist. And in my previous understanding is that in different institutes, they had a different protocol for heart transplant. And in our institute, the cardiovascular surgeon was relatively dominant in all the process of heart transplant and post-heart transplant care. And in some institute, some cardiologists will play a role in the post-heart transplant care and drug adjustment. And I would like to share some of the our institute's experience with you. And before we proceed the topic, I would like to say that in our institute, and cardiologist was playing a supplemental role to provide the post-heart transplant care. In our institute, the drug adjustment was controlled by the cardiovascular surgeon. And as cardiologists, just like the pathologists, they are providing their best to help the cardiovascular surgeon for the post-heart transplant care. And this will be the quick summary considering the role of endomyocardial biopsy. Well, in my concern, I think there's two major roles of endomyocardial biopsy in heart transplant cases. The first is called the pre-heart transplant evaluation. Just before we qualify the patient or listing the patient into the heart transplant program, we should have thorough evaluation of the patient's condition, including the etiology of heart failure. Is there any chance of the reversible condition of the patient's heart failure? And if there is no any reversible causes, and maybe the patient can be listed for future heart transplant, and it will be a journey of the waiting in Taiwan as well. And the other role is the post-heart transplant surveillance. And biopsy, in fact, until now, it still remains a gold standard for the rejection surveillance, especially during the first year. We had go further with this topic in the later slide. And it is also important surveillance when we know that the patient is developing acute rejection. So when the patient once develops acute rejection, probably the patient needs a follow-up surveillance by the endomyocardial biopsy. And this is a quick summary of the role of endomyocardial biopsy. And I think we can proceed further in detail in the following slides. So we begin with the pre-heart transplant evaluation. I think in most of the institutes and in most of the country, they are facing the same problem in heart transplantation. The main limitation for the transplantation is that there is so few donors and there's so many heart failure patients. So that with the limited resources, even the patient was listed for heart transplantation, I think around 30 to 50% of patients will die in the following 1 year because they are lacking the adequate donor. And so in our country, there is a limited, there is a strict regulation for indication for future heart transplantation. And this is quick summary of the indication of heart transplant in most of the institute. And you may see that there were always a saying that if there is an end-stage heart disease with a limited prognosis and a poor treatment responses, this is the indication for the future heart transplantation. For further etiology of heart transplantation, either including the ischemic cardiomyopathy, dilated cardiomyopathy, or other form of the cardiomyopathy like restrictive cardiomyopathy or hypertrophic cardiomyopathy. And also with some complex congenital heart disease, valvular heart disease would be the major indication for the heart transplantation. So the role of biopsy in these heart failure cases is to confirm the heart failure etiology and try to search any reversible causes and provide the potential curative therapeutic potentials. And this is the main role of biopsy before the heart transplantation. And as you may know that myocarditis is one of the catastrophic conditions in acute phase of heart failure. And the incidence was low, but the situation will become critical in cases with acute myocarditis. Most of the management of acute myocarditis will be the hemodynamic support, and some will propose with the IVIG supplement can provide a better clinical improvement. But in acute myocarditis, there is sometimes a limited role of heart transplantation because it is a kind of acute phase reaction, and there is still some treatment potential and waiting for the recovery of the heart. So in cases with potentially with myocarditis, probably we should not perform the direct heart transplant in cases with acute myocarditis. So in this particular situation, it is a pre-heart transplant evaluation like a biopsy to give the physician a definite answer with what kind of the heart failure situation this would be, and to see if there is any improvement potential through the biopsy result. And the biopsy can provide a tissue data, and possibly with some virus staining or virus isolation, and provide some etiology of myocarditis, which is sometimes treatable and curable. And of course, viral myocarditis is the most dominant causes in most cases of acute myocarditis. We had a bunch of study for acute myocarditis, and by far, tissue proof is also very important. And all the guidelines would suggest acute biopsy in stage of acute myocarditis. And just like I said, the value of the biopsy in pre-heart transplant situation like this is to confirm the diagnosis. Even the myocarditis is different diagnostic etiology. So whether it's giant cell myocarditis or some kind of viral myocarditis would be provided by the hints from the endomyocardial biopsy. And this is one of the management program in our institute, showing from the clinical evaluation with some non-invasive tests and the biopsy. In our institute, we try to manage acute myocarditis like acute myocardial infarction, because in cases with acute myocarditis, the situation can downhill or deteriorate very quick. So the earlier we can get a tissue diagnosis, the earlier the patient can benefit from the potential treatment and early hemodynamic support. And by far, there is some guideline suggestion for heart transplantation before the patient really received the heart donation. And according to the guideline statement, it said that it is reasonable to utilize a biopsy in a heart transplant candidate, which is suspect with infiltrated cardiomyopathy or some kind of inflammatory process like giant cell myocarditis or sarcoidosis. I think this disease could be treated by immune control, and the situation of heart can get improved after adequate treatment. So before the heart transplantation, it is important for some suspected cases to have adequate tissue diagnosis for his heart failure. And the other role of biopsy is that the post-heart transplant surveillance. Once the patient had received the heart, and probably he is now in his body with some immune reaction to accommodate with the donated heart and himself. So there is a bunch of tools to detect any incompatibility or some acute rejection between the heart and the donor. And from some of the listed modalities, I think biopsy is still remain the gold standard for rejection monitoring. And this is some list of some special character of biopsy, including some kind of the complication and some probably the main problem of some low concordance between each pathologist and some kind of sampling error can occur during the biopsy. And also we have other modalities, including the MR, some echocardiography findings, some tissue Doppler, some spectral tracking echo findings. I think some of these probably was for study purposes. And as a clinical physician, we can sometimes appreciate some of the discomfort from the patient. We had some finding from the even so-called routine echocardiography. And once the patient was in suspicion of acute rejection, I think biopsy remained the gold standard to confirm whether the situation is acute rejection or something else. And by far, this is from the International Society of Heart Lung Transplant Registry, and showing the gradual improvement of the long-term survival of heart transplant over the past decades. And I think according to the registry, probably 9 to 10 years of the survival can be guaranteed in most of the institute according to the registry. And of course, there are some expert differences. In Asia, probably the condition gets better, works better, because the long-term survival in the heart transplant recipient in either Korea or Japan is superior than the registry data. And I think over the 10 years, survival is guaranteed from these studies. But over the year, but even with the great success of the long-term survival after heart transplantation, still some cases are facing early graft failure. So the illustration showing that the reason of the graft failure or the problem that the patient will going to face after he received heart transplantation. In the light blue bar, in the deep blue bar is a acute rejection line, showing that in the early phase, the main cause of the acute of the heart transplant, the failure of heart transplantation was acute rejection. With later on, in over probably after 3 years after heart transplantation, the patient is going to facing problem of the chronic allograft vasculopathy, which in this figure is in a red line. So after 3 years, the patient is now facing a different problems. So the main problem of acute rejection probably is now focusing on the early phase of the heart transplantation. As for the acute rejection, there is a lot of the registry data, and I think this is the most believed. The saying is that most of the acute rejection happened within the 1 year after heart transplantation, and we're going to account about 11% of death, the early death of after heart transplantation. The rejection can as high to 20 to 30% in the first year, and there's probably some risk factors. A lot of the donor factor, HLA mismatch issues, and a lot of the environmental factors. And the main symptoms of acute rejection is usually fatigue, malaise, and sometimes with low-grade fever. As for the study, usually we cannot find a definite dramatic decline of the LV contractility. Probably we can observe some of the, for example, like septal wall thickening or posterior wall thickening, and some of 5 to 10% decline of the LV contractility, LV ejection fraction. And for cases with suspicions for acute rejection, I think we can say that just like all the guidelines says, biopsy is now the gold standard for the diagnosis of acute rejection. And the current concept, just like the repeat the statement, is that with the pathological-based diagnosis, using the biopsy to get a specimen is now remain the gold standard for managing acute myocarditis, acute rejection. And biopsy can be performed as a routine surveillance basis, and it can also be performed as a clinical-driven condition. If there is a clinical suspicion of a rejection, probably it's time to perform the endomyocardial biopsy. And I think this is very, very old, probably over 20 years, the concept is showing the recommended schedule for endomyocardial biopsy for the surveillance of the rejection. In this situation, the patient was supposed to be really asymptomatic. It's just a routine basis for post-transplant surveillance. Usually within 1 month, this in our institute we are still doing so. It is recommended to perform the biopsy weekly. And the problem, the patient probably will discharge 1 or 2 months after heart transplantation. It depends on how the patient recovers from the transplant. And the patient will going to be turned into outpatient follow-up. And after the successful 1 month after the transplant, during the outpatient clinical follow-up, the later on recommendation will be tri-monthly for the routine surveillance. And until 1 year, the previous recommendation is to have the yearly routine follow-up. And if there's any rejection events, and this when after discovering any acute rejection events, it is recommended to have the follow-up 7 to 14 days interval after finding of the acute rejection. And as I said that in the previous slide, it is recommended to have the annual biopsy surveillance, even the patient remain asymptomatic. But the question was raised now. In current era, the optimal duration and frequency of routine surveillance biopsy has been really challenging and questioned. Because in fact, with the improvement of the immunosuppressive therapy and with the advance in acute rejection management, and also with the change of our attitude toward low-grade cellular rejection, and the annual, the 1 year rejection rate, according to Regis data, declined from 30% to 24% in past decades. And low-grade cellular rejection was now supposed to be keep on the observation and no longer need strong immunosuppressive therapy. So the 1 year treated rejection declined from 23% to 12% in the past decades. And so the rejection events was really can be observed by clinical situation, and the rejection rate was now declining. So do we still need such kind of frequent biopsy? Was now being always asked by clinicians. And furthermore, because biopsy can also be an imperfect one, although it was now the only way to get a specimen for the pathology diagnosis. The problem would be it's a inpatient care procedure and can be costly, and there's potentially procedure complication. And for the specimen, there will be inter-observer variability from pathologists. And of course, it's a random sampling from the myocardium, so there will be a sampling error. And because of the sampling error, the reliability of the biopsy can be questioned. So although it's still a guideline, a gold standard guideline recommended, but it's an imperfect one. This is from Canadian recommendation 2 years ago, and they has now limited the surveillance to the early 6 to 12 months after heart transplantation, and the regular or routine surveillance after 1 year is now been abandoned by most of the institute, and because a lot of the issues that I just mentioned in the past, this is one now most of the institute have adopted this concept, and we have also know that there is different types of the rejection, and from the specimen, it is important to identify whether it's acute cellular rejection or it's a humoral rejection called antibody-mediated rejection. And the diagnosis, the pathology diagnosis is beyond the scope from my talk. And I just listed here telling you that even though there's some imperfect issue in a biopsy, it is still important in a particular situation to get an adequate specimen for the clinical judgment. And this is showing some of the pictures with the spatial stain showing the macrophage from CD68 staining and T helper cell from C4D staining, etc. And showing in this case is with humoral rejection. And just like I said, the other modality was now probably for study purposes, it's not really practical in clinical situation. So from the also from the guideline recommendation, in the past slides we are showing, or we are talking about the routine surveillance, but in cases of the suspicious for the acute rejection, by guideline, in this particular situation, it is still recommended to have early pathology diagnosis as early as possible. And once the acute rejection was identified, it will be recommended to have the follow-up 1 or 2 weeks later to see how we control, how the acute rejection goes, and how to see whether the acute rejection has been controlled or not. And a similar slide has mentioned that when years passing, the patient is now facing the coronary allograft vasculopathy. In later on, the chance of acute rejection declined further. But in our institute, we are still perform biopsy annually because in the condition, in case of surveillance for coronary allograft vasculopathy, it's a CAS procedure. So we will also perform the biopsy during the same CAS procedure. And for any institute beginning their heart transplant program, it is also important to address on the surveillance, and each institute will get their own experience from the strict or more frequent surveillance. I think they will get the institute will get their own data and find a way to treat the patient in their country. And just like in Taiwan, in National Taiwan University Hospital, in the early phase of our institute for beginning the heart transplant program, the surveillance was strict and the surveillance was really frequent. And now, because we are getting our own experience, and we now become using a more liberal way for the surveillance. And this is one of the recommendations for the coronary artery vasculopathy surveillance. And again, CAV is beyond the scope in my topic, and just like to say that it is still recommended to have annual coronary angiography follow-up, and with or without IVUS. And during the same coronary angiography follow-up procedure in our institute, we still perform the biopsy in most of the case. So the enemy for the transplant in early phase is acute rejection, and later on is a coronary artery vasculopathy. It's well known the enemy for the transplant. So in following slide, I would like to share some of detail of the biopsy procedure with you. I hope that you, because to understand the biopsy procedure, you probably need to hand on like mirror. And I would like to explain some of the procedure in the following slide. And I hope that you can understand my expression. And of course, there's a lot of indication for biopsy. And biopsy help for the diagnosis that I mentioned before. And the technique of biopsy developed early. And the first transvenous biopsy was developed in Japan in 1968. And the procedure and the device has been improved a lot. And biopsy is now most frequently used. The indication now is to detect rejection after cardiac transplant. And the risk of the complication rate of biopsy was diverse, the range from 1 to 10%. But for me, I think it's probably below 3%. And as for the patient who received the heart transplant surveillance, because the situation is quite different in cases without heart transplantation. The risk in patients who in the situation with the post-heart transplant surveillance, I think biopsy is even safer in these circumstances. So we're going to show you how we perform the biopsy. These were a list of the instruments that we use for the endomyocardial biopsy. In our institute, we use a choice-guided biopsy procedure. We perform the biopsy through transjugular or either transfemoral. And they are using different devices or instruments. For the transjugular biopsy, we use a fast cast sheath in length of the 45 centimeter. And alternative from the neck vein, we also use fixed guiding sheath. It's again 45 centimeter. Although it's 7 French in size. And for transfemoral, we are using the fast cast sheath. It is 98 centimeter in depth. And for biopsy, we use Cordis biotome, Cordis forceps. The forceps is 50 centimeter in length, and for transfemoral, the Cordis forceps is 104 centimeter. So the working distance of the biotome will be 5 to 6 centimeter, and it will be the distance that we manipulate the sheath of the biotome forceps. And in our institute, we also have different pharmaceutical from argon for the biopsy forceps. And this was how the sheath looks like. And we have always using a multi-purpose catheter. Later on, we will demonstrate how we use the multi-purpose catheter. And this will probably a routine basis for the pressure transducer some saline and some gauzes and some short sheaths. And for the vascular access for biopsy, we prefer from the right internal tubular vein and also from the femoral vein. Either from right and left is suitable. And for patient who lacks these vascular access, even though we do not recommend to perform the biopsy from the left tubular vein because the angle of the vessel tortuosity really limited the manipulation of sheaths and also our biocom forceps. And for the patient who lack adequate vascular access, probably subclavian vein is also an alternative access route. And sometimes we will make a subclavian vein puncture above the clavicle, and it is still acceptable and a suitable way. Okay, and this slide showing probably you have been really expertise with the jugular vein puncture, and this is showing the anatomy, just everything the same for like a CVC insertion, and we will get the venous puncture first. I insert the short sheath, 7 French short sheath in, and making the complete hemodynamic study and exchange into the vascular sheath for the further biopsy process, and these all the things that you know before. And this is alternative from subclavian vein puncture. And we initially we do not recommend it. Subclavian vein approach is that the space in between this small area by the limitation of clavicle can really great impedance for controlling our sheath. And sometimes when the patient move a little, all the devices can be stuck inside the root by the limitation of the clavicle. So probably we recommend using the subclavian vein approach, and of course from the subclavicle puncture. And just like I say, it will be safe to have the supraclavicle puncture accessing the subclavian vein. And this is the way we are using our multi-purpose catheter, and to insert our multi-purpose catheter into the pulmonary artery. In this stage, we are going to exchange our devices for the future, for the next biopsy steps. And it is a gentle way to stop our multi-purpose catheter around the tricuspid ring by avoiding a direct contact of the MP catheter tips into the right ventricle, because it sometimes can be dangerous and arrhythmogenic during this procedure. And by gently turning our multi-purpose catheter around the tricuspid ring, now the catheter can go smoothly without inducing any arrhythmia. And by placing our multi-purpose catheter into the pulmonary artery. And this is a similar procedure that we have done in the past. And again, we try to make a bend of the multi-purpose catheter around the tricuspid ring to avoid the tip irritation to the ventricle. And once the MP catheter is now placing into the pulmonary artery, we are now insert our sheath along the MP catheter. Now the MP catheter is now considered as a rail, so that we can deliver our sheath under the guide of our the MP catheter. And probably there was some limitation or some resistance when we try to insert our test sheath, and probably we need to some manipulate here, just like the illustration on the right panel. And we will probably place our sheath tip in the middle. Sorry, yeah, I just stopped the video right here. We'll probably stop our sheath tip around here. It's probably the upper RBOT area, and we will later on to replace our sheath, and we're beginning our test sheath here, and we will pull back the multi-purpose catheter, and to have our further manipulation of the sheath. Oops. Okay. Here we are now pulling our sheath outward little and try to have a counterclockwise rotation of the sheath. So after this kind of manipulation, you can see that from the left panel, the sheath is now facing the left side of the patient. And from the right panel, the sheath tip is now facing toward the spine of the patient. So it's like a double J condition. It's a J from the frontal view, it's a J from the lateral view. And we usually use a AP, straight AP, and the LAO is 60 degrees. And after a little bit pulling back and counterclockwise rotation, we are now pointing our sheath tip toward the places that we want, probably the right ventricular septum. Okay, so we will gently provide some contrast to have the right ventricle injection to opacify the right ventricle cavity. And the best way here is to have the adequate contrast volume so we can visualize the whole septum area as well as the lower free wall area. And the RV apex can be opacified. And from the lateral view, you can see that here is the interventricular septum. The free wall is around here, and the RV apex is around here. So we are now targeting our next steps of biopsy toward the ventricular septum, and we are going to confirm our position of sheath tip. The first, just like this video showing that we perform the Rb angiogram, and we can visualize the trabeculation of interventricular septum, of course, from the right ventricle. And also, we will connect our pressure transducer to confirm that it is now with the right ventricular pressure tracing, and make sure that we are not performing biopsy in the right atrium or sometimes in coronary sinus. Okay, we will be going to the follow-up biopsy procedure, and we will insert our biotome because of the design of biotome with hinge. At this moment, we need to pull back the sheath a little bit and to have the biopsy. Biotome opened with safe margin, and so we are now with, in our institute, we use a sheath guide to perform the biopsy. And just like I said, this is most of the design of the biopsy biotome forceps. When the biotome closed, it's really close. It's a blunt end, relatively safe to insert inside the ventricle. And once the biotome, you try to open the biotome, because of there's some hinge here. So once the hinge was still covered by the sheath, the biotome can never be opened. So we need to pull back the sheath a little bit, probably 1 or 2 millimeters. So they adequate space for the biotome to open. And by opening the biotome, by destroying the sheath and opening biotome, we are now not pushing hard on the biotome, so we will be the space will be safe most of the time. And once the biotome was opened, although it looks like sharp, basically the contact area was still large, and the risk of perforation was not so high because the contact surface was relatively large. And this is from the literature showing the rarity anatomy of biotome and the cardiac structure. And in this illustration, they are not using sheath guide. They are using a curved biotome to perform the biopsy. Sometimes the biotome was designed with Teflon coating, so we will still be safe. But in our institute, we usually use the sheath guide because we are more confident with the sheath guide, and I think it will be safer to avoid the biopsy at the wrong position. Just like say, we can using our sheath guide to perform the Rb Angiogram, and we can connect to the pressure transducer to confirm our the position. So sheath guide offers additional advantage in this kind of comparing it to this kind of sheathless biopsy. And we are also using alternative with the flex guide sheath, pretty much similar. And this is how we perform the angiogram here. And for the flex guide sheath, there is really visible ring of calcification at the tip of the flexor sheath. But in fact, the ring was not the true opening or the os of the sheath. This is one of the X-ray taken, and we are placing our biotome outside, contacting the opening of the sheath. So there is still a gap. You cannot be visualized. You cannot appreciate from the fluoroscope. So you must be very, very careful when using flexor sheath for the biopsy. And this is one of the case, and it's a acute myocarditis condition. And we had performed the right ventricular angiogram and performed the subsequent biopsy. And we are doing pretty much similar because we are supposed to have our sheath pulling back before we really insert our biotome. So because it's a case of acute myocarditis, you can see that we are performing this step very, very careful, very, very careful. Make sure that we are not really insert our biotome directly to the ventricular septum. And this is another case, and for acute myocarditis. And as you may see that here, we are not seeing too much trabeculation here. So it is not the good places for biopsy. So in this situation, we will now placing our sheath to different direction like this. This is the same patient with different position of the sheath. And here we are seeing the trabeculation, and I think it will be even the safer place for biopsy. And this is the case, pretty much similar for the biopsy. Okay, we keep mentioning about the wrong places for biopsy. This is very ancient picture showing that from the frontal view, pretty like a J shape of the sheath. And from lateral view, yes, it is still a J. shape, but by angiography, we can visualize the coincidence. From hemodynamic, it is not ventricle. So although it looks like a double J curve and like a ventricle position, but it is not a good position. It is the wrong places for biopsy. So I think sheet guide can offer some advantage in some of the situation. And we have mentioned that we also perform the biopsy through femoral vein. For patient, probably he had a double lumen over the neck, or probably he's now admitted for the routine angiography follow-up because he's going to have a growing puncture for the artery. So we are going to, along with the procedure, we're going to have the femoral vein puncture at the same, near the artery puncture. So in most of the case for the annual follow-up for the angiography surveillance in our institute, we perform the biopsy to the femoral vein. This is a case we try to set up for the transfemoral biopsy. Comparing to the neck vein biopsy, transfemoral biopsy usually you need to control or manipulate sheaths for a very long distance. It is a 98 centimeter sheath, and for the femoral biopsy, we cannot insert the sheath with the MP caster guide. So we usually use the wire to guide our sheath to deliver out the sheath into the ventricle. And as you may see that we had make some curve at this kind of a J-tip sheath, and we insert our wire into the ventricle, and now we deliver our dilator back, and we insert the sheath, and we can now placing our sheath into the right ventricle. Comparing to the transjugular approach, because there will be a tendency for the sheath turning upward. So we will begin our initial position over the lower septum, like this. And for the transjugular biopsy, we begin our procedure from the upper septum. And because when from the jugular vein approach, we're going to pull back the sheath for several times, and we're going to drop our position. And later, after 3 or 4 attempts of biopsy, now the sheath can facing really downward. So we will begin our jugular approach in the very beginning from the upper septum. And differently from the transfemoral approach, the biopsy usually begins with the relative lower side, because when we pull back the sheath from transfemoral approach, and the sheath will go into tilting up a little bit in each biopsy attempts. Okay, again, we after manipulate our sheath, targeting the ventricular septum, we will also make the Rb angiogram. Again, from frontal view, we will see in the ventricular septum trabeculation here, and we can also see the pre-wall area here and the Rb apex here. And from the lateral view, still the tip of the sheath should pointing a little bit toward the spine, and it will be a safer position like this. And again, we are performing the biopsy with pretty much similar approach. And this is a relatively straightforward one. And we can perform our biopsy by similar manner, by pulling the sheath a little bit and insert our biotome and open the jaw and take some specimen like this. And sometimes it indeed matters, because the contact indeed matters in sometimes. And as you may see from the lateral view, and probably you can understand that. Let me stop a little bit here. From the lateral view, we're going to insert our biotome. At the very beginning, remember that the septum is probably in the position. Here. It's probably the ventricular septum is probably here. And now we are now opening our biotome in this kind of manner. You can see that the contact, you can probably imagine that the contact of the biotome was only part of the jaw can approaching the ventricular septum. So in this particular situation, we like to turning our biotome by turning the axis into like this. In this particular situation, is now the jaw, the biotome is now in a horizontal plane of the sheath, the ventricular septum, so that we can get a closer contact of the biotome to the ventricular septum, and we can get adequate specimen by manipulating the axis of the biotome. And this is each relative anatomy of the Rb Angiogram, the RBOT, ventricular septum, and the Rb cavity. And, this is the Vascular sheath that we have mentioned before. And still, we can forcefully deliver everything into so-called coronary sinus. Please just be very careful when perform the biopsy. Oh, I think this ancient picture showing that he tried to perform biopsy into the coronary sinus forcefully, and he's not delivering the sheath. It is a wrong procedure. I think the procedure has been adjusted. So it is always important to repeat confirming the position of the sheath tip and perform a safe procedure for the patient. Okay, this is a following example showing that inadequate position of our sheath. And from the frontal view, we are not, from the frontal view, which is on the right side, we are not placing our sheath tip toward the ventricular septum. So when we biopsy in this manner, probably we can forcefully deliver our sheath toward the free wall and increase the risk of perforation. So in the same case, we do some manipulation of the sheath, and by turning the sheath tip toward the spine, and from the frontal view and lateral view, you can see that we are now have ventricular septum visualization from the Rb Angiogram. And again, this is a bad position, and we are now inject our contrast and showing that the sheath tip is now indeed really facing the free wall. So again, we manipulate again, so now the sheath tip is now facing toward the spine, and of course facing the ventricular septum, and it will be more appropriate in this position. So as for the sampling consideration, we would recommend to keep the forceps remain closed until it becomes totally removed from the body, and ideally, the sample can be 1 to 2 millimeter in diameter, probably in volume 3 to 4. And the expert would recommend to sample in different area of myocardium to make sure we are not keep taking the biopsy at the same site, and because some acute rejection can develop focally. So we try to biopsy a different area. And Indeed, because we are repeating our biopsy by pulling the sheath a little bit, so we are changing our position sometimes, unless the sheath tip was initially stuck in a groove of the ventricular septum. In this particular situation, you are going to digging a hole in the ventricular septum. I think it was not suitable, and because we are now our sheath tip is relatively freely movable, and we are now changing our position all the time. So this will be not an issue if we use a sheath guide, because we will manipulate the sheath a little bit so we can have a different area of specimen above this area. And usually 6 specimens are required, and Mira said that probably 7.
Professor.
Yeah. I think if the specimen is adequate, 1 specimen is enough for the histological diagnosis, but probably sometimes we're going to have different spatial stains. So additionally, with 2 or 3 more specimens will be reasonable, and the pathology will really thankful for me, for the physician to perform the biopsy, because the more they can help, the more they can have do the pathological examination and make the accurate diagnosis. So now this is a picture showing how much? 1, 2, 3, 4. Wow, more than 6. Yeah, it's something similar like this. This is from different patients, different number, different morphology. Yes. The specimen look like this. And usually the specimen, the myocardium is brownish. And in particularly red specimen, usually is coated with a lot of the blood clots or fibrin. And for some cases, the biopsy can get some whitish tissue. Probably is coming from the long period of the endomyocardial fibrosis. And when the tissue was fibrotic tissue predominant, you will become whitish from the grossly inspection. So for early patient, early phase of heart transplantation, it usually is in brown color and elastic but in cases with acute rejection, firstly, you can see that the tissue can be edematous, and the structure was not as clear cut like our specimen picture here. Regarding the complication of the biopsy, the complication rates can range from 1 to 3%, and for cases with post-heart transplant, I think probably 1% is most encountered number. And there's a bunch of potential complications. And well, I think the cardiac rupture is most catastrophic one. But in cases who receive heart transplantation, at the very beginning, the patient can usually have chest tube drainage, so the risk of tamponade can be low, and because it's a new surgical wound, if a large cardiac rupture encountered, probably cardiography will be performed by the cardiovascular surgeon. I think the things can happen, but will not be lethal in this kind of situation. For the cases who receive the heart transplant for a long period of time, I think the pericardium can, with the myocardium, will be really some adhesion, and the risk of tamponade can also even low, unless you really perform biopsy in the wrong side and make a big hole in the wrong position. Otherwise, the small leak can usually self-limited if you perform the biopsy in a careful manner. And there are also some reported complications. including increment of the tricuspid regurgitation, and sometimes with some coronary cameral fistula. It is not uncommon, but I think need no further treatment in this particular situation. And by far, we are talking about the biopsies through right ventricle. And in cases, in some institute or some expert will propose using the right ventricle biopsy in most of in their own expertise. And for the left ventricle biopsy, well, I think there's still a lot of the risk, including potentially with air embolism and the thrombus within the sheath, and the thrombus or air in the sheath can introduce into arterial system and causing the risk of stroke. And alternative. In addition, if you perform the left side biopsy, it will going to be a heparinized procedure. And once you encounter the perforation complication, probably the bleeding can be more severe in some of the situations. Otherwise, the procedure is pretty much similar from the right ventricle biopsy, and because ventricle is a concentric one, and you can direct all the position as you want. Just be careful not to injury to the mitral apparatus causing cold rupture. Otherwise, the procedure is pretty much the same, and just be very careful about the embolic issue. I think the ventricle biopsy is alternative procedure, but for me, I think if we can perform right ventricle biopsy, I would prefer using through the right ventricle biopsy, because the problem of a lot of the potential stroke was reduced, and I would be really feeling comfortable in this situation. Okay, this is of course it's an ancient one, and we are performing the right ventricle biopsy, and of course the patient was not heparinized, and so the thrombus can develop within the sheath, and this is one of the pictures showing a lot of the thrombus coming from the sheath. And okay, this is a funny one, because in the early time in our institute, we have limited resources. So we are using reused forceps. This is the reused one in a very, very early period. And the reused one, it just doesn't work well sometimes. And once it is now in this situation, it cannot be withdrawing back into the sheath, and probably will cause some vascular injury in this particular situation. So if you had adequate instrument, please just don't use the reused baton. Okay, so this is going to a quick summary of heart transplant, the biopsy in heart transplantation. I think it will be my final slide here. And as you may know, that biopsy is indicate before the transplantation to make the definite diagnosis of the heart failure. And it is now a gold standard for post-heart transplant surveillance. And by far, at the very first 6 to 12 months after the transplant, periodic surveillance is still recommended. But after that, probably there's some controversial opinion. And after that, it is usually a clinical-driven biopsy procedure. And when patient failed a malaise or some kind of general discomfort, and by the routine echocardiography, we can visualize some interventricular septum thickening or some decline of the LV contractility. Probably it's a situation to have the biopsy to confirm whether there is a acute rejection or not. So after that, after 1 year, the biopsy will going to be a clinical driven one. And when the biopsy had confirmed in case of acute rejection, it is now recommended to have the follow-up biopsy, probably 1 to 2 weeks after enhancement of immune therapy, to see whether the acute rejection has been controlled or not. And thank you for listening. And this is my final slide. And this is a quick summary of the role of endomyocardial biopsy in heart transplant. Thank you.
Okay. Thank you very much, Dr. Chen, for your full lecture today. And for the audience, we open the discussion now. If you have any question, please just raise your hands, or you can type it in the chat box. While we're waiting for the question, the direct question from the audience, we have some question here. The first one is from Dr. Dian Yenya. Sebelumnya, mohon maaf, please I will use bahasa. You can speak bahasa?
No.
Okay. Bapak Ibu sekalian, silakan kalau yang mau memberikan pertanyaan bisa diberikan secara langsung ataupun melalui chat box. Mau pakai bahasa Indonesia ataupun bahasa Inggris, persilakan. Oh, ada Dr. Ana Ulfa Rahayu di sini. Dr. Ana Ulfa, please. Can you hear me, Dr. Ana Ulfa?
Yes, thank you, Professor Chen. Thank you very much for sharing your broad experience in this field. I have some questions. This patient has to face several times of myocardial biopsies under fluoroscopy. And as we know, the dangers of fluoroscopy for the patients. In your experienced hands, is it not possible to do it under echo guidance? Number two, I would like to know how many heart transplants performed in your center, and how many per year, and then how many myocardial biopsies performed per week in your center. We don't have a pathologist, but next to our hospital, there is a mother and child hospital who has a pathologist. Do you think that this pathologist should be trained in your center to know how to detect the rejection event? Thank you.
Okay, thank you very much. You want to...
Okay, thank you for your question. Well, because I just mentioned that in our institute, the transplant program was now handled by a cardiovascular surgeon. And for the number of the biopsy, for the number of heart transplant, I think it is now over 600 cases. And probably we're going to have 2 or 3 cases per month. And the reason is that because it's a national organ perfusion program, and the patient was now listed according to the disease severity. So that once there is a suitable donor, and the heart will deliver to the most the patient in need. Mm-hmm. And so it is now a fair distribution of all the donated organs. And in Taiwan, probably there is 3 or 4 major institute performing the heart transplant. Probably 2 or 3 in the northern Taiwan and 1 in southern Taiwan. And it depends on how the situation of the patient goes. And for the biopsy procedures, well, because I just mentioned that over the years, the need of the routine surveillance decreased. So about 10 or to 20 years ago, as I'm still in my fellowship, well, I think probably it's 8 biopsy per day.
Per day?
8 biopsy per day. And because the schedule was so busy, we are performing the venous puncture outside the classroom. And we were going to send back, after the procedure, we're going to send back the patient and now returning the cases which are already negative punctured to have the quickly have another biopsy. And until recently, and the most frequent procedure was done for the initial, for the early phase of the transplant. We are still using the weekly surveillance. So the biopsy was now performed for the new transplanted one every week. And so probably in this time, probably we had 2 cases of biopsy procedure in one day, probably my procedure, my class time, and probably 4 cases per week. 4 cases per week.
4 cases per week. And how about the echo-guided biopsy to minimize the fluoroscopic deviation?
Yes, yes. I think echo-guided biopsy is a good concept, but I've never been trained for this purpose. And because echo-guided biopsy, unless it's ice, but transthoracic echo, because it's a 2D dimension, it is hard to visualize the radiative condition or to identify the biotone, the tip of the biotone from the 2D echocardiography. So it takes a lot of time to probably additionally, you spend additionally a lot of time try to identifying the proper positions from the echo, but finally it will confirm your position again back to the fluoroscope. So if you can understand the relative anatomy of the right ventricle through the fluoroscope, I think echocardiographic biopsy probably may not be practical, but maybe there was some development in the future, and to see if we can benefit from the new concept of echocardiographic biopsy.
Maybe you have tips and tricks to minimize the fluoroscopy, especially for the sensor, which only use a single plane imaging system.
Oh, of course, I think biplane is really important. And once you hands-on for the procedure, you will probably come to realize that you need to make sure a lot of detailed things, and maybe I cannot cover from my talk this time, but by adjusting your own style or your own practice, you will get familiar with the procedure and to limit the risk.
And how about the experience of the pathologists in detecting rejection? Do they need a special course for that?
Well, in our institute, we had a pathologist who is really focused, expertise in reading the myocardial specimen. I think it depends on their the staff in the pathology department, because as I know that they in pathology department they divided their specialized field in different parts. some for hematological diagnosis, some for soft tissue disease, some for malignancy disease. And in our institute, we indeed had one professor who was really expertise in the myocardium specimen. So I think definitely they need a special training to gaining their own expertise in the future.
As far as I know, here it's only Professor Chen who really biopsy and endocardial biopsy.
Yes.
Ya, cuma ada satu aja ahlinya, Dr. Ana di sini. Beliau sebenarnya udah pensiun juga, tapi beliau mendedikasikan waktunya untuk membaca semua kasus-kasus ini, myocardium. Okay, we are. Dr. Ana, do you have any feedback for the questions, for the answers?
Yes, thank you. You also perform heart rate implantations in your center?
Yes, yes.
And in your experience, how is the long-term result compared to the heart transplant?
Comparing transplant and PAVI?
LVAD.
Oh, LVAD. LVAD was performed mostly with the cardiovascular surgeon, and because that improved over time, and now the durable LVAD is now I think the satisfactory results, and because the donor of the heart transplant was really few, and that will, I think, also in the Western country is also expected to a growing business and also a clinical practice in the future. And the durable VAC can provide or guarantees some benefit in some of the cases.
Okay, thank you very much, Professor Chen. We're moving into the question from Professor Bambang. Professor Bambang, would you like to deliver your question directly?
Thank you. Thank you very much, Professor Chen, for this. So I already wrote down my question in the chat room.
Yes.
Recent publication from St. Vincent Hospital Victor Chang Foundation that a cardiac MRI could replace the endomyocardial biopsy, because as to my knowledge, endomyocardial biopsy have an invasive procedure. They have also artifact like punching of the biofilm and something, some sampling error. So it needs a spatial technician and spatial pathologist to read that. However, from the publication from St. Vincent, nowadays they try to do cardiac MRI to replace, to see the rejection of the heart transplant. That's what I read. What is your opinion?
Okay, thank you. This is a very good question. I think my answer will be biased. Well, I think I'm still in the concept of seeing, believing in most of the clinical practice. For example, in cases of suspected malignancy, lung nodule, and all the features of the image showing possible lung cancer, we still need some pathology diagnosis. And I think this is a definite one. Cardiac MR probably can provide hint, something just like echographic finding, and to confirm the diagnosis. I think probably pathology diagnosis is still very important. And moreover, we had two types of acute rejection. One is cellular, one is humoral, and it takes different treatment using a different treatment method. So probably to get adequate specimen is still very important, in my opinion. Of course, I think my answer will be biased.
And maybe regarding the process of the rejection itself, which post-heart transplantation will have kind of denervation, so the symptom would be masked.
Yes.
So
Yes.
the CMR will reveal the lesion after they're becoming a symptom.
Yes.
Right.
Yes. Yes.
So the fibrosis might be detected, but after several years, after the fibrosis, that the rejection occurred.
So you agree with my opinion?
Maybe Professor Bambang has.
As to my knowledge, to know a rejection, the symptom is a heart failure. So we know that when we put a new heart, so we put a good heart. It's a good heart to the recipient. So if there is a symptom of heart failure, the patient will symptom of heart failure like diastolic function. So we could suspicious by clinician there is a acute rejection. On the other things, I agree with you that doing a biopsy is in a new heart, it's transplant heart. New heart is easy. It's not like biopsy on the amyloidosis that difficult. It's danger. But in transplant heart, it's a new heart. It's safe. However, sometimes because we can to the tricuspid apparatus to make some trouble, and also it's need a special expert to read that, special technician to processing the color. That's in the future. I do hope that cardiac MRI with T1, T2 imaging and will decrease non-invasively to detect a rejection. That's my opinion. That's my opinion.
Thank you very much, Professor Bambang, for the opinion. And we have one more question here from Dr. Diani Niarti regarding the management for the patient with low-grade cellular rejection. What clinical signs are left that have to be evaluated for the patient? And when will you perform next endomyocardial biopsy, or we just escalate the dose of the immunosuppressive agent? I think you.
As I mentioned that in cases with low-grade rejection, because we are not seeing the patient routinely in the outpatient clinic, so we usually receive the referral for the biopsy, and probably the patient can still have some symptoms of acute rejection, malaise and weakness and some low-grade fever. And but usually it was some disturbance of the immune suppression drugs. So the patient definitely need to be hospitalized for surveillance and to check the drug label, peak and trough, and to see how the condition goes. And the patient condition can change over time. And so still follow-up biopsy in cases is usually a case by case, depends on the really situation. And the treatment recommendation by far is still controversial, and probably the patient probably don't need aggressive immune suppressant drug for additional control. And I think the cardiovascular surgeon will have a better experience in this particular field.
Okay, thank you. There's another question, Professor. This center also performing heart transplant in pediatric patients. Right?
Yes.
Regarding that population, what is your concern about the endomyocardial biopsy in pediatric patients? Is there any specific rules or?
Well, in cases with a pediatric patient, we had a pediatric department to handling the cuff procedure. And of course, because of the size limitation and lateral access problems, and unless it's a big children, probably there's limited entry for the biopsy in these cases. And yes, the image study will be important for this particular situation.
In big children, you also perform it in.
We had a pediatric department. Yeah, done in pediatric department.
Okay. Ladies and gentlemen, any other question? We still have 5 minutes for discussion. If you have any question, please just raise your hand or type it in the chat box. Okay, I will read another question here. Another serious complication of EMD was pericardial effusion or even tamponade. You mentioned that in post-heart transplantation, it will be much easier to minimize the risk. But maybe in general, if we perform the myocardial biopsy, do you think we need to perform echocardiogram after the procedure?
Okay, very good question. We will recommend echocardiography after the procedure. This was written down in the postcast order. So routinely we'll have the echocardiography for the patient who either whether it's a fresh heart or those with a post-transplant condition. Usually post-biopsy echocardiography is recommended. It is safe to have this post-biopsy follow-up.
And how about the antibiotics? This is some invasive procedure, so
yes,
you recommend the administration of antibiotics?
Yes, this is a different concept between cardiology and cardiovascular surgeon. Cardiovascular surgeon will still think that the preventive antibiotics is still mandatory in their concept. So the patient was coming from the cardiovascular department. So the patient even received the biopsy, they still use prophylactic antibiotics.
Prophylactic. I didn't get it. What is the difference? So the cardiovascular surgeon.
Well, I think it's an aesthetic procedure in my concept, and it's not a big one. So we don't think that a simple cast procedure needs prophylactic antibiotics.
Even for post-heart transplantation, which receives a lot of
in my opinion, but we follow up the recommendation from the cardiovascular surgeon.
Oh, okay.
Question?
Yeah, please.
Yeah. Professor Chen, in Taiwan, how can you promote the people to do more donation? So education for donor heart, because the problem for cardiac transplantation is limited of donor. So we appreciate that in your country, promotion to give a donor heart is very, very good. That's what do you think? Is there any suggestion for us how to make this promotion of donation of the heart better?
Well, I think this is the most difficult question today. And indeed, also in different countries, this is the most important question. I know that in some countries, it is strict regulation that you need to donate your organs. And but in Taiwan, we do not have this kind of law or this kind of regulation. And probably it takes some cooperation from the medical field with some other field. For example, some charity. As in Taiwan, we had a charity of some Buddhist, and also probably we can with some social worker. Also, we can have some drama which is showing how important to have the organ donation, and it's a touching story for all the people. And
TV drama.
Yeah, TV drama. So the patient will get to understand that that it is a good thing to donate your organ. And like one of the saying in Taiwan that you only have the right to use your body, but you didn't own all the things of your body. So once you pass away, you will no longer use your body. You're going to give your body to those who need your body.
Okay.
May I have one more question?
Okay, Dora.
Is it true that transplant patients are prone to have skin cancer compared to normal population? Heart transplant patient has prone to have skin cancer.
Well, according to the registry data, because of the use of the immune suppressant, the risk of the risk of developing malignancy in the future was higher than general population, not only skin cancer. For example, like lymphoma or some solid organ malignancies, the risk also increased from the registry data, and we are also seeing cases who develop the malignancy after transplant. So the malignancy issue, the emerging of the malignancy can be one of the limitations years after the transplantation.
Thank you.
Thank you very much, Professor Chen. And I think this is the end of our discussion today. I may have to conclude this lecture. The first one is heart transplantation is a team-based intervention. So we, as a first-timer institution, we will have to build a very solid team regarding this. And it will depend on each institution how to manage it. And endomyocardial biopsy could be utilized either in pre-transplant or post-heart transplantation in terms of diagnosis and monitoring patients with heart failure. And we have, as a first-timer institution, have to address the surveillance of the endomyocardial biopsy itself. Do you have any take-home message to deliver?
Well, I think biopsy after heart transplant is relatively safe. It is in this patient population, it is the most safe one. In contrast to acute myocarditis patient or amyloidosis, and just prepare yourself. It will be a safe procedure. And probably we can, after obtaining some of the specimen in the future, some study ideas will coming up from those specimens. Everything will in a good direction to improve the patient outcome.
Okay. Thank you very much once again, Dr. Ying Shun Chen, if I'm not mistaken.
Yeah, perfect.
Okay. Ladies and gentlemen.
Your boss.
Yeah. Professor Bambang, Dr. Rasari, Dr. Diani, Dr. Soseka, it's all in heart failure division. Jadi, please let me Konfident bahasa. Baik, terima kasih. Oh ya, sebelum acara ditutup, kita mau minta foto bersama. Bapak Ibu sekalian, silakan buka kameranya dulu sebentar. Nanti arahannya apa?
Boleh saya hitung ya, Dok?
Oh ya.
Yang lain masih ditunggu, tunggu untuk buka kamera dulu. Udah ya, sudah siap ya?
Ya.
Baik, kita foto bersama. 1, 2, 3. Sekali lagi. Boleh arahkan jempolnya juga. 1. Maaf, tunggu sebentar. 1, 2, 3.
Ya.
Ayo. Sekali lagi ya, maaf.
Oh, sekali lagi.
1, 2, 3. Oke.